everyone, and welcome to AI Arthritis Voices 360. This is the official talk show for the International Foundation for Autoimmune and Autoinflammatory Arthritis, or AI Arthritis for short. My name is Layla P.L. Vallette, and I'm a person living with lupus and Sjogren's disease, and I am the Health Education Manager here at AI Arthritis. Today, I have a special guest joining me, Dr. Julius Birnbaum. I met Julius this past ACR as he was going around to the different booths, and he let me know that he was publishing a book for patients, and I knew I wanted to get him on the talk show to talk more about it. Here at AI Arthritis Voices 360 talk show, we have an equal seat at the table as experts in our disease as patients, so we're a little bit more informal, and we like to go on a first name basis with our guests and co-hosts who are also doctors. So Julius, please let us know a little bit more about you.
Oh, sure. So happy to be here on the show. I have a lovely wife and 3 children, Jeremy, Aaron, and Samantha. And I will say, as a result of this book, they now think that I know a fraction of what I'm talking about. So that's been one of the gratifying benefits of the book. Originally, I grew up in New York City. I've lived there for 30 years, and I moved on to Johns Hopkins in Baltimore, where I did my fellowship. And right now I'm at the University of Pittsburgh Medical Center in Pittsburgh, and I've been here for 4 years. Love it a lot.
Awesome. And I know that we're going to be talking a little bit about the neurological manifestations of lupus and Sjogren's. So why don't you tell the audience a little bit about how you have such a big emphasis in neurology?
Sure. So I initially did my residency in neurology, and at the end of my neurology residency the last year, I started taking care of patients with a lot of fascinating complications, rheumatic diseases. So this included lupus patients with a lot of brain lesions. It included Sjogren's patient with painful disorders, rheumatoid arthritis patients with spinal cord injury. And I realized if I wanted to take care of these patients, I needed to have a broader understanding of how these diseases not just affected the brain, but the heart, the lung, and kidney as well. So I returned and I did an internal medicine residency. And subsequent to that, I completed a rheumatology fellowship at Johns Hopkins Hospital. So all told, this was more than 9 years of training after medical school, but I thought it was well worth it. And when I was at Hopkins, I managed to combine my training in a synergistic way. So I was able to open up what I termed a neuro-rheumatology clinic. And that's when I had a unique opportunity to care for patients with diseases at the interface between neurology and rheumatology.
That's awesome. I think one of the biggest things at AI Arthritis that we always try to emphasize is that the arthritis that we're talking about is a systemic disease. So knowing that, like you said, every different organ, including the brain and all of the different parts of the body, can be affected. So it's really cool to see how you got your path to having the intersection of rheumatology and neurology. And I think specifically right now, a lot of the hot topics that patients are talking about have to do with brain fog, fatigue, pain, and all of these have to do with neurology as well. So it's going to be so interesting to hear a little bit more about what you have to say. And so during our first meeting, you told me that you wanted to discuss the intersection of rheumatology and neurology, specifically in lupus. And in lupus and Sjogren's. And as a lupus and Sjogren's patient myself, of course, I was definitely interested in hearing more. Specifically, like I said, a lot of people in our community are dealing with brain fog, fatigue, mental health issues. And those are like the really heavy topics day to day because it affects your day-to-day life so much. And sometimes we don't get a lot of advice on how to deal with those specific symptoms. So I'm sure that, getting some background on them and maybe a little bit of advice from you will be super important. And I think what's really cool about this as well is that for the past year, we've been creating these different resources on the different stops of the patient journey. And this information will definitely be able to fit into either the coexisting conditions section or even just, living with the disease, which has to do also with progression of the disease and different side effects that come with that. So that'll be amazing. And so maybe you can start with telling us a little bit about the neurological side effects of Sjogren specifically. And I know that in the Sjogren section of your book, you talk a lot about neuropathies. Can you tell me a little bit about what that means?
So sure. So when neurologists use the term peripheral neuropathies, what's implied is a certain anatomy. So the peripheral nerves, for example, connect the spinal cord to the skin, to muscles. And when the peripheral nerves can become injured, it could cause weakness, but also a lot of what we call sensory symptoms, such as numbness and tingling. And there are also particular neuropathies, which are called small fiber neuropathies, which particularly cause a lot of neuropathic pain. So when I say neuropathic pain, patients might experience burning pain, patients might experience shot-like sensation, and patients might also experience extreme exquisity to touch. So for example, bed sheets at night rubbing against their feet can cause intolerable pain. So these are the type of pain that could occur in neuropathies, and we refer to them as painful neuropathies.
That's really interesting because I went to a talk at this past ACR as well that was about pain and talking about the different types of pain, neuropathies being a type of them, basically saying like some of the pain that AI arthritis patients or patients with these rheumatic diseases may have may also be very similar to the type that fibromyalgia patients have, which kind of seems like it's tying in similarly to what you're talking about with the peripheral neuropathy. I never really knew that peripheral neuropathy was an exact symptom or could happen from lupus. But the first time that I had a really big flare, they put me on gabapentin because I was having pins and needles. I was having all of this go on with my nervous system that I didn't really understand what was happening. But now that I put the two things together, I think that's what was happening, is that there was some neuropathy pain going on at that point when I was having that first big flare with lupus.
Yeah, and I'm just saying the neuropathy pain can be somewhat amorphous and difficult to understand because it's assault and so many different sensory symptoms. And the sensory symptoms can present with such an incredible heterogeneity of symptoms to like you're describing with yourself, like the tingling, the numbness, that can happen. I think what happens also is that patients resort to language. Language could actually be, exquisitely lyrical. So I've had patients tell me that, if someone's taking a blowtorch to my feet, or, their feet are open when they're going in a body of ocean. And I think that when you use this intense language, what you're trying to do is convey to your physicians how much they're suffering. And physicians, by their training, are used to telltale terms like tingling, numbness. So sometimes going off script and becoming more adept in understanding how these are personalized to you, that could actually lead to some symptoms becoming marginalized and even undiagnosed in certain ways.
Definitely. I just had a discussion with some of our volunteers about this exact thing, about one of the resources we should come up with is the different description words on how to describe your pain so that you can be a little bit more detailed when talking to your physicians, because that may be part of the problem, is just the breakdown in communication of what you were talking about. And basically, like, to kind of go into it a little bit more of a breakdown, there's a difference in the pain that we're talking about of like the numbness, tingling, burning versus a mechanical pain that may happen, say, if you sprain your ankle or if you have some other acute injury. The description words would be completely different. It'd be a sharp, tight pain, when
Exactly.
it comes to the, spraining your ankle or breaking your arm. And that's really important for patients to have that language that you're talking about, to be able to communicate what they're trying to say to the doctors.
Yeah, I think you're right. We use the term inflammatory pain. So, like when you're seeing your ankle and it might be a sprain, like you're talking about, you'll see redness, you'll see warmth, you might see a bruise. So you could see the actual injury itself. When you have neuropathic pain, there's nothing that visibly you can see. You see your skin, and patients a lot of times understand, and they don't understand why it's so enigmatic. Like, where is it coming from? Where is the pain generator? So it's important to understand that in neuropathy, it's the nerves inside that connect muscles to spinal cord to skin. So you're right. There's a big difference between what you can see in inflammatory pain, like when you sprain your ankle, versus a neuropathic pain, which is actually invisible to the eye.
Yes. And we talk, a lot of these different diseases are invisible, like what you said. And so it can be really tough, even for patients themselves. You're like, am I really experiencing this pain? What is happening? Because we can't see it. So I think that can be really tough for some patients to deal with. And I think, like you were saying, kind of go explaining the difference between the central and the peripheral nervous system, with the central being the brain and the spinal cord, and the peripheral nerves being everything else that is going to be connecting your body parts to the central nervous system. And I think we talked a little bit about the neuropathies and Sjogren's. How does that differ with Sjogren's versus lupus? And I see that we may talk a lot about injury with spinal cords with lupus as well. Like, what's the breakdown of that?
Yeah, so I think that a lot of the neuropathies that are highlighted and more better diagnosed in Sjogren syndrome, or Sjogren's disease, I should say, because Sjogren's has now appropriately changed its designation from a syndrome to a disease. I think that this reinforces to rheumatology wider community that it actually is something deservedly become called a disease. So let me emphasize that myself. So
Absolutely.
Sjogren's disease, it could cause a lot of different types of neuropathies. So the nerves themselves can be injured in different ways. So for example, we have tiny sized nerves that can be injured. And when these tiny sized nerves are injured, this is what we call a small fiber neuropathy. So again, the small fiber neuropathy gives rise to descriptors like we just talked about: burning pain, shock-like sensation, sensitivity to touch. And what happens, and why small fibers neuropathies are undiagnosed, is that they require special diagnostic testing. So the diagnostic test of choice in a small fiber neuropathy is to take what we call a punch biopsy, which is a punch biopsy of the skin. And then pathologists look at this biopsy under a microscope. And what they try to understand is if small fiber nerves are making it to the top layer of the skinless, which is called the epidermis. So what pathologists can see in a small fiber neuropathy is that these tiny nerves, they wiggle in the skin layer, but they never try to get to the epidermal layer. So the epidermal layer is devoid of small fiber nerves, and this is what it's called a decreased nerve fiber density in the epidermis. And that's kind of the buzzword that we use to describe small fiber neuropathies. It requires special tests. And until recently, it was not recognized that these special tests needed to be done for small fiber neuropathies.
Wow, that's amazing to hear about. I think that's we never hear about the layers of what you're talking about when we think about our pain. And so I think just even understanding that information can help patients feel more empowered to talk about their symptoms and feel like it's a real thing as well.
Yeah, and what we do in our manuscripts, our research studies, is we actually try to get the biopsy slides and put into pictures what pathologists are seeing. Because you're right, I think it's very powerful to patients that they could have a certain anatomical locus so they could say, here's where my nerves are not working as they should. So once you have a visible portrait of how your small fiber neuropathies are being diagnosed, it helps reaffirm to you that, hey, what I'm experiencing is real and organic, and it's not just in my head.
Yeah, right. Like with lupus nephritis, you could get the biopsy of the kidney and you know exactly what class it's going to be. So it's like very similar. It's taking it as, the same way, like pain is being caused by these injuries and that's what's causing it. So I think that, yeah, like you said, like we both said, it's very empowering. Um, yes, is there any information that you have about lupus patients getting the injury to spinal cord? Is that a common thing that happens?
So it's uncommon, and now it might only affect 1 to 2% of lupus patients. But here why it's really important. Because if you're a lupus spinal cord patient and it's not treated appropriately, unfortunately, you might spend a lifetime of irreversible paralysis and be relegated to a wheelchair. So, what I kind of discovered when I was at Hopkins, one of my initial research studies, is that spinal cord injury in lupus is actually quite heterogeneous. So, it's not just one type of spinal cord injury, it's actually two. So the first type of spinal cord injury that was undiagnosed and underrecognized is what we call the gray matter variant of lupus myelitis. So we say gray matter because it affects the central part of the spinal cord where there's a lot of nerve bodies. And what we identified was that this gray matter myelitis was actually not inflammation of the spinal cord, but was actually a spinal cord stroke.
Oh,
So
wow.
if you suffered an irreversible stroke, that's why you're going to be so decimated. But we identified also that there's a crucial warning sign. So all of our patients with gray matter myelitis, they had this prodrome where they were unable to urinate for hours or even days beforehand. And often they were misdiagnosed as having a urinary tract infection. And this is what we identified, that if you had a lupus patient come in without another cause for being challenging to void, difficult to void, that this was your warning period. And if you intervene with high dose steroids at this time, you could prevent patients from suffering a lifetime of being unable to walk and being relegated to a wheelchair. So as the
Wow.
great matter of it, yeah, it's a stroke, but the good thing is that we recognize that there's warning signs and ways to intervene.
Exactly.
So
Yeah. I mean, if it's like you said, if you can take a high dose of steroids to totally, avoid that or at least postpone it for the time and try and figure out what's going on, that is so important for ER doctors and primary care doctors to maybe know, if they have a lupus patient, just in case, even though it's only 1% or 2% that it may happen to.
no, exactly. And then we also identified that there's a different pattern of spinal cord disease, and we called it the white matter variety because it tends to affect the myelin coating that's on the outside of the spinal cord. But one myth that we were able to debunk is that for a long time, a lot of physicians thought that multiple sclerosis was a type of complication that can occur in lupus patients. And what we identified that multiple sclerosis was actually extraordinarily rare in lupus patients with spinal cord disease. Instead, they were affected by white matter, and the initial attacks could be quite severe. It could still affect the nerves and muscles. Patients could still be relegated to wheelchairs. And this is after a few attacks. In multiple sclerosis, in contrast, you could develop similar weakness, but whereas the white matter variety in lupus can lead to spinal cord injury and maybe wheelchair dependence within 5 to 10 years. Similarly, multiple sclerosis patients can have slower evolution of weakness. So again, this was the second myth that we tried to debunk, and that multiple sclerosis is actually very, very uncommon as a manifestation of lupus, especially the spinal cord injury. So these two different types of spinal cord injury, each different of themselves, but each of them much, much different than multiple sclerosis.
Wow. Yeah. I mean, I can totally see how people might have, confused the two for a little bit, but that totally makes sense that it's, just, the different inflammation on the different parts of the spinal cord. I have a question about like SLE, like systemic lupus, like progressing into CNS lupus or lupus that affects the like the neurological side. How often does that happen for someone who has SLE, or like if someone's control, usually controlled, like for me, I'm on Benlysta and hydroxychloroquine, and that's kind of it. And I've been stable for a few years. How common is it for there still to be peripheral manifestations and then central manifestations of lupus to come, if my inflammation is quote unquote controlled for the most part?
Yeah, I think it's a great question. I think for the most part, if your lupus complications are controlled, experience, if you have initial lung or kidney, joint or heart disease, that if you are able to tamp down the ferocity and the inflammation of these organs, the neurological complications actually due to lupus are less commonly to occur. Now, I want to emphasize when I say neurological complications due to lupus, because also what we've identified is that neurological complications can occur in lupus, but actually the majority of lupus complications can stem from non-lupus origins. So, for example, you might have fatigue, and that could be associated with medications. It could be associated with disorders of glands, such as the thyroid glands. And these are not directly due to lupus. So when you have neurological complications that occur after your lupus has been effectively treated, you could still develop neurological complications, but they might not directly stem from lupus.
And I think that that can also be something that happens, is that whenever you go to the doctor and they say, and you say, like, I have this going on, I have that going on, I feel like sometimes there could be a blanket of, oh yeah, that's a side effect of lupus. That's a side effect of your lupus. I feel like I hear that a lot. And I'm like, I just want to bring it up because maybe it's not the lupus, maybe it's something else. And I feel like like you said, it should be emphasized that rheumatologists and primary care doctors should know that and should be trained to look for the non-lupus origins of some of these different
Absolutely.
symptoms that may be happening.
I think that's so true. And I think what happens, without being pejorative, is that a lot of physicians can be so overwhelmed by these neurological complications. So let's say, for example, a lupus patient develops seizures, and the seizures can be due to an infection. The seizures can be due to kidney disease, which is not necessarily active at that point. Seizures might stem from disorders that can increase or lower sodium, but they're scary to see. So when you have someone with seizures, there's seismic shaking of the arms and legs. So if you have a lupus patient with seizures, I would say, hey, this is so overwhelming. Who wouldn't say that's not due to seizures? And a lot of patients are errantly sometimes put on immunosuppressive medications for neurological disorders, even though those neurological disorders are not due to lupus. So what happens in the case is that the immunosuppressive medications at best are not effective, or at worst make you more prone to infections.
Definitely. Yeah, that is so interesting to hear about. And I think that just this information, being able to get that information out there that you were saying about debunking whether MS is an escalation of lupus symptoms, and all of this is a really good place for patients to kind of start to understand the neurological side. It's something that we are not often warned about or told about on an every visit basis. It's not like, hey, make sure that you check out for these specific symptoms when you come back, and all of this kind of stuff. So it's I think that that's something that we can also maybe give some advice on, is what symptoms may come up that patients can look out for, where it is a warning sign, like you said, with not urinating for a few days for the spinal cord injury. Is there any other general symptoms that you can let patients know that might be a warning sign that there may be something going on the neurological side for lupus or Sjogren's?
Well, I think one of the things that's recognized is what are your symptoms, again, like we talked about, of a neuropathy. So again, being very tuned to your body and noting whether you're having any of these central or pain symptoms, and try to identify it at this earlier and more incipient phase, because you're going to know your body better than physicians. So I think, in a sense, you want to be cognizant of the fact that the neurological complications can occur in a wide variety of ways, but being sensitive to your body, knowing any perturbations or changes, I think that's the biggest goal. And it's in turn like knowing your body, having the conviction that something is dissimilar to you, and then also having the conviction that, hey, this is something that I really think is important that I should report to my physicians.
Definitely. Like you said, with any shocking feeling or snapping feeling, the warm, or sorry, not warmness. We were saying, oh yeah, like warmness as well. Like any type of, if you look up the information for nerve pain,
Right.
there's can be some descriptive words that you can look up to see if that may be what you're feeling. If it's not necessarily aching pain that you usually feel on an everyday basis with your lupus, that can kind of be a sign. Um, okay, let's see. We did touch about this a little bit in the beginning. This brain fog symptom that, everybody feels like they have at some point with lupus and Sjogren's. There's a lot of talk about brain fog. The scientific name that we use is cognitive dysfunction. What is the connection between brain fog and these diseases? And is there anything that you can recommend for brain fog?
Yeah, and I think when we use the term brain fog, that's an incredibly descriptive symptom that might explain some of the underlying mechanisms. So again, brain fog is a metaphor, and right away you describe something that's very incisive, and I think your physician will recognize this as a common symptom. So when we think about cognitive impairment, we try to think about whether the cognitive impairment is affecting certain anatomical loci at the top of the brain, which is called the cortex, or the underpart of the brain, which is called the subcortex. So, for example, when we talk about Alzheimer's disease, this affects the cortex of the disease, and it's certain deficits, which I call the A's. So, aphasia, difficulty with speaking; alexia, difficulty reading; acalculia, difficulty calculating. So, there's an A pattern of deficits that occur in what we call the cortical cognitive impairment, like Alzheimer's. So what fortunately happens in lupus is, this is important to emphasize, it's not a neurodegenerative disease. So you're not going to progress towards all the horror images that you might know if you had a older loved one, a grandmother or grandfather with Alzheimer's disease. And I think that's one thing that can bring relief to my patients, is I tell them, I'm not minimizing your cognitive impairment at all. What I want to do is to tell you that cognitive impairment in lupus does not progress. And I have a colleague who had a research fund that was funded by the NIH, and she wanted to use sophisticated imaging studies to see whether that he can predict certain types of cognitive impairment. But the research study was really over in the first 1 or 2 years, because here they had all these gorgeous tools to predict deterioration, but there was no deterioration. And so that's become a little bit better known, that lupus cognitive impairment does not progress. Now, the other thing with the brain fog, and similar, this is a theme that we've talked about, is that in many lupus patients with brain fog, there's other underlying symptoms that are not strictly due to lupus. So, for example, fatigue is a debilitating cause of brain fog. And if you manage to try to elicit and treat some causes of the fatigue, the brain fog could get better. In addition to fatigue, pain can be an important correlate or associated with brain fog. So if you manage to treat the pain, the fatigue gets better. Sleep disturbances can also be a cause of brain fog. And what I think is actually undiagnosed in lupus patients is sleep apnea. So sleep apnea can affect more obese patients, but not necessarily. It can affect patients who have normal weights. So you want to have a partner who you could ask, like, am I snoring a lot? Do you hear me stop breathing at night? And that's regarded as sleep apnea. And I've seen a lot of patients with lupus cognitive impairment who, when identified as having some sleep disturbance and particularly sleep apnea, their cognitive impairment can get better quite quickly. And we talked about depression as another cause of brain fog. So there's all these different contributors to brain fog in lupus patients. And again, I think that the central theme that we've been talking about is that all these symptoms that you can see in lupus, they might stem from non-lupus causes.
Definitely. And I see that these three symptoms sometimes bunched together when it comes to the ACR or ULAR with fatigue, pain, and brain fog. It seems like definitely what we're seeing is that there's a correlation between all of them, and kind of trying to isolate each individual symptom and trying to address that to see if it may help with the other symptoms seems like a really good way to address it with your healthcare providers, and seeing how, like you said, if you can get better sleep, if that will help the fatigue and the brain fog, if you can, you know, figure out how much the pain, how to treat your pain, then that may also help with the sleep and also help with the brain fog and fatigue. So there, it seems like, everything with these diseases, everything's connected. It's all systemically connected. So just trying to pinpoint what exactly may come from can be really difficult, but definitely worth the work to try to figure out in order to alleviate those symptoms.
No, absolutely. And I think what's interesting, we were talking about depression in lupus patients and in patients with rheumatic diseases. And I think it tends to be deprioritized for a variety of reasons. When you come to your physician's office and you're describing more tangible complications that they could see, a rash or joint pain, swollen joints, then this is more obvious. And I think what happens is that depression is deprioritized because you have a pressure maybe of a rheumatology visit, 15 minutes, and they'll ask, review a symptoms question as to heart, lung, and kidney disease. And depression tends to be at the lower end of the hierarchy. And again, this is not because of any malicious or derelict things that are offered by physicians, just goes under recognized. And the second thing that I talk about is a separate chapter in my book devoted to depression, is depression's not tantamount to sadness. So depression is a disease as complex as any syndrome. So depression hurts. Depression isn't just sadness. It causes you to withdraw from pleasures that you enjoy. It forces you to withdraw from family, friends, and loved ones. So depression hurts, and depression causes fatigue, for example. Depression causes cognitive impairment. So you have to dig a little bit deeper and not just say, am I sad? But am I experiencing all these wider types of symptoms that can be associated with depression?
Definitely. And I think one last question that I have for this section of the interview is with Sjogren's disease, like with lupus and RA. Sjogren's disease is a very common, maybe second diagnosis that you may get afterwards. And I hear that Sjogren's has more neurological effects than maybe lupus and RA as well. What are some of the very common neurological manifestations of Sjogren's specifically that we may not see every day, but that say if you have RA and you're not even sure if you have Sjogren's, that may be kind of like I may have Sjogren's if this happens. Is there anything that you can pinpoint?
Sure. So it's the peripheral neuropathies. So like you're saying, patients with one autoimmune disease can have another autoimmune disease. So let's say you have both Sjogren's disease and rheumatoid arthritis. If you start developing these small fiber neuropathies that are seen more prototypically in Sjogren's, then at that point you would say, hey, my neurological complications might stem from Sjogren's as opposed to rheumatoid arthritis. Now, that's not to say that small fiber neuropathies can occur in rheumatoid arthritis, but probably at a much lower frequency. So knowing specifically the types and patterns of how neurological complications can occur in Sjogren's disease. When Sjogren's disease co-occurs with another rheumatic disease, you'll have a better sense of understanding when I'm having a neurological disease due to Sjogren's disease and when I'm having a neurological syndrome due to non-Sjogren's autoimmune diseases, which are co-occurring with Sjogren's.
Got it. Yeah, I think that you just kind of put a light bulb in my head, especially like one thing that patients may also have a mistake with is thinking that neurological symptoms just have to do with the brain as well. I think that's something that may occur, is that when you think of neurological symptoms, you're thinking about brain fog, you're thinking about dementia or Alzheimer's. That's what neurological means to a lot of patients. So just like you said, remembering the nerve pain can be in any other part of your body, the peripheral side of the nervous system. So knowing that just because it's not necessarily something happening in your brain doesn't mean that it's not a neurological symptom as well. So just keeping that in mind as well.
Right. And the last thing I'll say about this is that the neuropathies tend to be undiagnosed in a lot of different rheumatic diseases. So, for example, if you look at lupus, there's this nomenclature, ACR, the American College of Rheumatology nomenclature of different neurological symptoms. And you could look at even the diagnostic criteria of lupus. So nowhere in the nomenclature of neurological lupus and nowhere in the diagnostic criteria of lupus is small fiber neuropathies talked about as well. So when we looked at neuropathies in lupus patients, the neuropathies were frequent and prevalent. It was just underrecognized. So I think this just emphasizes again that when we start our understanding how neurological disease and small fiber neuropathies, that they're similar in different rheumatic diseases, although undiagnosed, even lupus, that the neurological symptoms need to be revamped in understanding. And I would argue that the diagnostic criteria and the ACR nomenclature of lupus needs to be greatly expanded and revised.
Absolutely. I think that that's a really good place to start with kind of, the ACR is always the biggest place for all of our different rheumatologists to get the proper information and to get the proper naming and nomenclature, like you said, of the different symptoms and all of those things, so that that information and that knowledge can be passed down onto their patients. And so I think that that's super important, like what you said. And thank you so much for giving us all of that information on the neurological manifestations of lupus and Sjogren's. And I'm sure that there's so much more that we can even talk about. And anybody that's super interested in learning more about these different topics, Julius has a lot of other interviews and webinars and lectures that are coming up that we'll let you know about at the end of the episode. So stay tuned to learn more about that if you want to hear more about these topics and all the places that you can find them in the future. And so let's go into talking about the book. And Julius's book is called Living Well with Autoimmune Diseases, a Rheumatologist's Guide to Taking Charge of Your Health. And I think that this is such an amazing topic and book for a rheumatologist to come out with, because, as patient organizations, we always talk about empowerment, advocacy, making sure you advocate for yourself. But to hear it from a rheumatologist and to hear it from an expert that we should also take charge of our health, I think that that's super powerful. And I thank you so much for bringing this to the table. And I'm so excited to hear a little bit more about your book and how this project started for you and where you got your inspiration.
Yeah. Well, the title didn't come from myself. The title came from my wife. And the cover, which has a someone by the ocean who's running with a dog, that came from my 9-year-old daughter Samantha. So you always have to look elsewhere for where you get original ideas. But the book is entitled, like you said, Living Well with Autoimmune Diseases: A Rheumatologist's Guide to Taking Charge of Your Health. Now, there are different features of this book, but the one thing I want to emphasize, as you're mentioning, is that the core message of this book is empowerment. And I regard it as autoimmune empowerment. It's a unifying theme that occurs in all chapters of this book. So the book is relatively unique in that it offers a wealth of information about many different rheumatic diseases. So there are chapters on lupus, chapters on Sjogren's disease, chapters on vasculitis, chapters on rheumatoid arthritis, chapters on psoriatic arthritis, chapters on myositis, and chapters on scleroderma. So it provides a one size fits all so you could learn about these different rheumatic diseases. But the one reason that I wanted to juxtapose these chapters is to emphasize that there is an inherent interconnectivity between these diseases. So I think we talked about already how if you have one autoimmune disease, you could be affected by another autoimmune disease. But what's really fascinating also is that medications that initially were developed for one autoimmune disease is now being applicable to many other rheumatic diseases. So learning about these medications and how they're nimble and spry and how they leap across diagnostic boundaries, I think is important. I think when you're talking about these diseases, family members often are affected by autoimmune diseases, not necessarily the same one. So, for example, if you have lupus, you might have a parent with lupus, but you might have a parent with Sjogren's disease or a parent with a rheumatoid arthritis. So this offers you the opportunity to go to your family and say, hey, here's a book that you might find relevant. So that's the first feature of the book is chapters on other rheumatic diseases. The second feature of this book is I intentionally wanted to put in this book that there are relevant features or issues that are not necessarily autoimmune in nature, but they have a big role in caring for patients with different rheumatic diseases. So there are chapters on fibromyalgia, there's chapters on diet, there's chapters on sleep. And I think these tend to be sometimes put in different books as if the diseases themselves and these non-inflammatory diseases are of lesser importance. But I did think that it's important to put chapters on fibromyalgia and on diet and depression in this book. And finally, I think a third feature of the book that I think is really important to readers is that I wanted to open up my clinic. So I wanted to show readers the gripping drama that I'm privileged to see on an everyday basis. So I think that when readers read about these narratives, what happens is that in my patients' voices, they'll hear their own voices. And in my patients' struggles, they'll hear their own struggles. And what happened when you recognize this, you actually feel less lonely and isolated, and you form bonds with patients you might not have otherwise met for the rest of your life. So these are the features of this book. So I would say the unifying theme is autoimmune empowerment. Then the first feature is the discussion on the different diseases in this book. The second is discussion on non-autoimmune diseases that can occur in rheumatic diseases. And finally, third feature is using stories to help illustrate to readers and patients themselves how these diseases unfold in time.
Absolutely. And I think two important things that you talked about in those features are one, here at AI Arthritis, we have a very unique grouping of autoimmune and autoinflammatory arthritis diseases. But the reason why those are grouped together is because we knew that a lot of these patients have similar symptoms and wanted to be able to create a community of these patients that have similar similar things that occur in life, similar experiences, similar diagnostic journeys, just to feel that community, like you were saying, because these diagnoses and these diseases can be so isolating and feel like you're the only one in the world that's experiencing something like this. So I think that
Sure.
that's really cool that that's something that you acknowledge and something that's super important for us here at AI Arthritis as well. And I think the second thing being that, like you said, patients need to feel the empowerment of themselves to be able to take charge of their disease. Like you said before, also, patients are going to know their body the best. And that's
Yep.
why we are also considered experts when it comes to our diseases, because we're the expert in our body and the doctors are the experts in the medicine and the anatomy and all of the other amazing things that may occur with these diseases, but there is always that one missing piece of your own personal experience that the doctor needs to be able to make the best assessment of what's going on at that time. So I think that those are such amazing themes for you to highlight in the book.
Thanks.
And let's see. Patients who get diagnosed with autoimmune diseases often feel really overwhelmed. And I'm sure that you may get that in your office all the time. I'm wondering if there's something specifically that you tell patients that are overwhelmed and maybe having such a hard time dealing with these heavy diagnoses.
So that's a great question. And you can understand why patients feel overwhelmed because they might come in with a certain set of symptoms. And the last thing they might hear is that the mosaic of these symptoms reflects an autoimmune disease. So what happens is the first question I get, well, can my autoimmune disease be cured? And what I tell them, quite honestly, in the year 2025 is that autoimmune diseases can't be cured. So initially, patients might be crestfallen or be pessimistic. But I say, hold on. So let's think about high blood pressure. So high blood pressure is a chronic disease. It can't be cured, but it can be absolutely well managed. High cholesterol, same thing, diabetes. There's no cure, but if you take high cholesterol medications and medications that treat diabetes, you can still live a very long and gratifying life. And I think that's what happens very uncommonly is that when patients hear that diseases can't be cured, they might hear that it can't be managed. So there's a difference between cured and managed. So I want to emphasize to readers and newly diagnosed patients that these are chronic diseases that can be very well managed. And that's the first thing. And then the second thing I tell them when it comes to autoimmune diseases, you often hear the metaphor, there's light at the end of the tunnel. But oftentimes I think we need to shift this thinking. And there's also light at the beginning of the tunnel. And that's why when you diagnose someone with an autoimmune disease like rheumatoid arthritis, you might be discussing treatment at that very first diagnosis. And you're discussing treatment potentially with medications that might not have been available more than 20 years ago. So there's this burgeoning line of medications being approved year after year after year. And the options for you being treated are so much more than where it could have been 20 years ago. So that's why I try to tell my patients that there's light at the beginning of the tunnel. And if you hear that sense of hope right at the time that you're diagnosed, I think that it makes these diseases a little less overwhelming.
Definitely. I think we talked a lot about metaphors during this whole interview and during this talk. And I think metaphors are a really good way to talk to patients and to really get them to understand what we're trying to say. And I like the light at the beginning of the tunnel because there is, right? If you think of an actual tunnel, there's light at the beginning, there's light at the end. But if you also think about it, there's lights that are also in the middle of the tunnel as well. There's the lights that guide you through the tunnel. And I think that that's also a great metaphor for a chronic disease. There's going to be lots of little lights and lots of little parts of darkness, and that's kind of the nature of the disease. But at the end of the day, there's going to be light. There's going to be times where you do feel good. There's going to be good days, there's going to be bad days. So I really like that metaphor. I might steal that one from you.
Thanks.
Alrighty. And I know that we talked a little bit about depression in the previous section. I know that with lupus, depression is listed as an actual symptom of the disease. It may not be that way for a lot of the other rheumatic diseases, although we know that it's something that occurs quite often. Is there any last bits about depression? Any little tidbits that you want to share from the chapter of your book about depression?
Well, I think that recognizing depression right at the outset is really, really important. If depression goes by the wayside and it percolates over many, many years, it can just remain something that think it's part of you, something that's immutable and can't be changed. So I think, again, recognizing that depression can be managed and greatly improved, similar to any other what we call organic complications. So depression can be treated in much the same way that joint and skin disease can be treated. So I think recognizing depression as occurring early on can have a gratifying response to treatment. And then it could grant you a sense of optimism and resilience. So the whole way in lupus is affecting you can be managed with a lot more hope.
Absolutely. And like you said, noticing it as a chronic disease as well, that can be treated, that can be, there can be interventions for that, and not thinking that it's something wrong with you, which I think is what a lot of people may discount depression as, but you have to really realize that it is a disease. But yeah, definitely seeing depression as a full-on disease. It's not just, something that's going on in your head, but something that can be treated and should be treated for you to be treated as a holistic person that has this chronic illness. So I think that that's really important for patients to also feel empowered about. Okay, I think that this comes to the end of our interview. I have one last question. You talked about the 3 features of your book, but what is the biggest takeaway that you want patients to get from this book? And give us a few reasons why they should go out and get the book.
But I think the biggest takeaway in this book is that, like we talked about diseases, we talked about diseases that impact, such as fibromyalgia. We talked about stories. But at the end of the day, what I want to emphasize again is that readers should feel empowered. And again, autoimmune empowerment. So I really think that different strategies I use in the book, that when you walk away from this book, I think that it can be a transformative experience. And just that sense of empowerment and that sense of owning your disease and knowing that you can make important changes, that sense of empowerment is something that I want to be the parting message of this book.
Amazing. I think that is so powerful for patients to know, coming from a rheumatologist. And yeah, thank you so much for being here today and for sharing about your book and for the information about the neurological side of Sjogren's and lupus. I think that this information will really help a lot of patients to understand what may be going on with them if they were not sure if this pain that they're feeling was something that is related to their lupus or Sjogren's disease. So I thank you so much for that. And
Sure.
yes, please let us know what's coming up next for you, and where we can find your book.
If you want to learn about my book a little bit more and where it could be bought, you could look at juliusbirnbaum.com on the website, and it could be purchased at Target. It could be purchased at Barnes and Nobles, and could be purchased on the Amazon websites.
Awesome. So anywhere that you can find books, you can probably find this book. Again, the title is Living Well with Autoimmune Diseases, a Rheumatologist's Guide to Taking Charge of Your Health. And like we said, you can go check out juliusbirnbaum.com. There's information about the different shows and podcasts that he's been on, as well as some upcoming. And we wanted to highlight a few of the different webinars and lectures that he's going to be having with other patient organizations that are amazing partners of ours as well. So we want to make sure that we champion all of the work of our partners. So a few of them are on April 8th at 6:45 p.m. Eastern. There's a Lupus and You segment that's going to be about lupus and pain management. Julius is going to be talking about fatigue, and that's with Lupus Foundation of America. On the 24th of April, he will be talking about inflammatory arthritis, a guide to medications, lab tests, and management of side effects with the Arthritis Foundation. With the Association of Women in Rheumatology, he'll be talking about Sjogren's and neurological complications. That's coming up in the next few months, as well as a series of different talks with the Autoimmune Association having to do with introduction to Dr. Birnbaum's bio, discussions about multiple different autoimmune diseases, depression, and patient empowerment, which are all, super important topics. As well, lastly, is an interview with AARP about psoriatic arthritis. So for all of you listening to the AI Arthritis Voices 360 talk show, I'm sure that one of those talks will be interesting for you to take a look at and to get some more information on. And I wanted to talk a little bit about what AI arthritis has in the funnel right now as well, what's coming up for AI arthritis. As all of you may know, if you are a recurring audience member, on May 20th, we have World Autoimmune and Autoinflammatory Arthritis Day, and there's always lots of activities that come up with that. So make sure to stay tuned for more information about our social media campaign and live stream that will be going on the week of May 20th. This year, we also are we have a fundraiser that you can create your own race team. So if you go to givebutter.com/AI Arthritis Day 25, you can either donate or you can start your own race team to be able to get donations for AI arthritis for this World AI Arthritis Day. And as you all know, we do an auto theme for this Awareness Day. So we are excited to see all the different car puns that you have describing your disease or your symptoms to those of a car. Maybe your rheumatologist is the mechanic and is helping you tune up your car. Let us know all those different fun car puns that you may have, and post them on social media on World AI Arthritis Day on May 20th. And you can use the hashtag AI Arthritis Day and hashtag Learn Arthritis to be able to elevate your social media posts so that the whole community can see it. And yeah, that is what we have in our funnel. So at AI Arthritis, we don't just represent the patient voice, we are the patient voice. And with your support, we can amplify it even further. If you found value in this talk show, consider making a donation to help us continue producing impactful conversations, bringing all stakeholders to the table to discuss patient-identified issues and patient-infused solutions. Visit aiarthritis.org/donate to help make a difference together. Thank you again for tuning in to this episode of AI Arthritis Voices 360. You can find AI Arthritis on all major social media platforms at IFAI Arthritis. And that's a wrap. We will see you next month for the next episode of AI Arthritis Voices 360. Thank you again to Dr. Julius Birnbaum for being such an amazing guest here on the show. Alrighty, bye everybody.